Shulmit, a warm welcome to you as a patient on the World Lymphoma Day. And Dr. Nair, warm welcome to you as a physician, as a person who helps out all the patients. And especially because you have, I mean, not because, but because you have been my teacher and you have been my physician, and I have warm regards for you. Um, I think we've lost Dr. Nair.
Yeah, I think we have. So just give a second.
So while we connect with Dr. Nair, I think what we'll do is in this thing of time that we will start with Shulmit, and Dr. Nair is back. Sorry about these technical, but it just shows that we need to meet more often rather than be on the Zoom. Because
Sorry,
I think
yes, technology fails.
yeah, Zoom has also got tired of all of us using it, So I think that's the reason they want us to meet. And I can assure you, it's a pleasure to meet everybody and to be in physical, presence of each other rather than just being on a camera or on a screen. So, Dr. Nair, you missed the best part of it from me saying that you treated me while the cancer was being treated. And we've had a lot of interactions, lot of arguments, and lot of fun things. But it was good in the long run. So let me ask you the first question, Dr. Nair. I wanted to know a little about what is lymphoma, and are they also considered as blood cancers, or are there any thing which is like which is it very common in India? So maybe you can answer all the things together.
Okay. Which language do you think I should pick? Hindi, English?
Well, it doesn't matter. You can use any language, Dr. Nair.
Okay. So lymphomas is basically, I'll use a mixture just in case somebody is more comfortable with one of them. So lymphoma is a malignancy. Malignancy मतलब एक प्रकार का कैंसर है. ये लिम्फेटिक सिस्टम और ब्लड सिस्टम से है. तो कई लोग इसको रिलेट करते हैं कि ये ल्यूकीमिया या ब्लड कैंसर के जैसे है, लेकिन ये एक्चुअली जो लिम्फ नोड्स होता है उसमें गांठ हो जाता है और उसे हम लिम्फोमा बोलते हैं. और लिम्फ नोड्स के अंदर जो सेल्स होता है वो लिम्फोसाइट्स होता है और बेसिकली इट इज अ कैंसर ऑफ द लिम्फोसाइट्स. लिम्फ नोड्स में हो सकता है, लेकिन सिर्फ लिम्फ नोड्स तक ही सीमित नहीं रहता है, ये और भी अलग जगह में भी हो सकता है जिसको हम एक्स्ट्रा नोडल लिम्फोमा बोलते हैं. तो इसीलिए कई बार आप सुनेंगे कि लिम्फोमा स्टमक में हो गया या लिम्फोमा ब्रेन में हो गया या लिम्फोमा बोन में हो गया. तो अलग अलग जगह जहां भी ये लिम्फोसाइट्स ब्लड से जाते हैं वहां पे अगर वो एबनॉर्मल बन जाते हैं, रुक जाते हैं, प्रोलिफरेट करते हैं और ट्यूमर बन जाते हैं तो उसे हम लिम्फोमा बोलते हैं. पहले there was very simple classification. The first lymphoma that was discovered by the person who's called Hodgkin's was about more than 150 years ago. एंड इसीलिए जो उन्होंने डिस्क्राइब किया था उसको हम हॉजकिंस लिम्फोमा बोलते हैं और जो उनके डिस्क्रिप्शन के अंदर में नहीं आता था उसे हम नॉन हॉजकिंस लिम्फोमा बोलते हैं. लेकिन जैसे जैसे साइंस आगे बढ़ती गई है और अलग अलग प्रकार के इन्वेस्टिगेशंस आए हैं और हम लिम्फोमा को और क्लियरली सब टाइप कर सकते हैं, तो अब ऑलमोस्ट 55 से ऊपर प्रकार के लिम्फोमास हो गए हैं. और हर लिम्फोमा मालूम करना भी इम्पोर्टेंट होता है क्योंकि कई लिम्फोमास का ट्रीटमेंट थोड़ा सा अलग होता है लेकिन लाइफ सेविंग और क्यूरेटिव होता है. तो इसीलिए एक अच्छा डायग्नोसिस लिम्फोमा का सब टाइप मालूम करने के लिए ट्रीटमेंट शुरू करने से पहले बहुत ही इम्पोर्टेंट होता है.
So, Dr. Nair, before we go into the subtype and description, one of the most common questions that people say, like they feel Hodgkin's and non-Hodgkin's. मतलब non-Hodgkin's मतलब उतना खतरा नहीं है और Hodgkin's है तो बहुत खतरा है. So would you like to talk about this, or do you think it is more related to, the doctors knowing about it, or you think the patient should know about it? or is there a particular age group when it can be Hodgkin's and it can be non-Hodgkin's? Just a little difference between the two would really help us out.
So जनरली हम लोग मानते थे कि हॉजकिंस लिम्फोमा ज्यादा क्योरेबल है, कम उम्र में होता है, उस उम्र में लोग ट्रीटमेंट भी ले सकते हैं, जरा ज्यादा जबरदस्त ट्रीटमेंट भी ले सकते हैं और क्योर होने का चांस ज्यादा होता है। बाकी जो लिम्फोमास होते हैं उनको हम नॉन हॉजकिंस लिम्फोमा बोलते हैं। फर्क यह है कि जो हॉजकिंस लिम्फोमा होता है वो एक नोड में होता है और उसका जो स्प्रेड होता है वो लिम्फेटिक स्प्रेड होता है, तो इसलिए एक नोड से वो अगले नोड में जाएगा, फिर उसके अगले नोड में जाएगा, तो काफी टाइम तक वो सीमित रहता है लोकली या लोको रीजनली। जो नॉन हॉजकिंस लिम्फोमा होता है वो ब्लड से स्प्रेड करते हैं सेल्स, और इसीलिए एक गांठ गले में होएगी और एक गांठ पेट के अंदर हो सकती है, क्योंकि ब्लड से वो इजीली अलग अलग जगह स्प्रेड कर सकता है। तो बेसिक डिफरेंस तो कैसे ये बीमारी स्प्रेड करती है और इसीलिए कितना टाइम मिलता है डायग्नोसिस के बाद उसका स्टेज बदली होने में और ट्रीटमेंट करने के लिए। जनरली हॉजकिंस लिम्फोमा अर्ली स्टेजेस में पकड़ा जाता है क्योंकि जो गांठ होती है वो नेक या बाजू का एक्सिला में होती है, तो इसीलिए वो मोर इजीली ऑलमोस्ट 75% उस एरिया में होती है, वो आउटवर्ड एरिया होता है। और अगर कुछ लिम्फ नोड होता है या स्वेलिंग होता है तो जनरली टेंडेंसी रहती है डॉक्टर से पूछने के लिए कि ये क्या है। नॉन हॉजकिंस लिम्फोमा जैसे मैंने बोला कई बारी अलग अलग जगह में होता है और कई बारी बाहर होता ही नहीं है, या पेट के अंदर होता है या चेस्ट के अंदर मीडियास्टाइनम के अंदर होता है, इसलिए कई बारी पकड़ने में भी मुश्किल होती है। हॉजकिंस डिजीज जनरली यंगर एज ग्रुप में होती है और फिर कई पेशेंट्स को 60-65 के बीच में, तो उसको बाई मॉडल पीक बोलते हैं, यंग एज एंड एक और पीक आता है ओल्डर एज में। नॉन हॉजकिंस लिम्फोमा अलग अलग प्रकार का कोई भी एज में हो सकता है। बच्चों में जो होते हैं वो एग्रेसिव लिम्फोमास होते हैं जिनको हम बर्किट लिम्फोमा बोलते हैं, और ओल्डर एज में जो लिम्फोमास होते हैं उनको हम CLL क्रॉनिक लिम्फेटिक ल्यूकीमिया, वो भी एक प्रकार का लिम्फोमा होता है, या फॉलिकुलर लिम्फोमा या मार्जिनल जोन लिम्फोमा या मैंटल सेल लिम्फोमा बोलते हैं, जो ज्यादातर ओल्डर एज ग्रुप ओवर 65 इयर्स में होता है। और मालूम करना इसलिए जरूरी है क्योंकि सब में, जैसे मैंने पहले भी कहा, कि थोड़ा थोड़ा ट्रीटमेंट में डिफरेंस होता है। कईयों में हम इंटेंसिव थेरेपी देते हैं जैसे बच्चों के लिम्फोमास होते हैं, कईयों में हम स्टैंडर्ड ट्रीटमेंट देते हैं जैसे डिफ्यूज लार्ज बी सेल लिम्फोमास होता है। और जो एल्डरली लिम्फोमास होते हैं अगर उनको ज्यादा सिम्टम्स नहीं होते और गांठ छोटी छोटी होती है और कहीं भी प्रेशर नहीं दे रही होती है, तो कई बार हम उनको अंडर ऑब्जर्वेशन 4-5-6 साल तक भी रख सकते हैं, जब तक कि स्वेलिंग की वजह से कोई ऑर्गन के ऊपर डैमेज होने का चांस नहीं हो। वो लाइफ थ्रेटनिंग नहीं होते हैं, लेकिन हम सिर्फ डैमेज नहीं चाहते हैं कि कोई भी वाइटल ऑर्गन पे हुए, तो इसीलिए उनको हम ऑब्जर्वेशन में भी रख सकते हैं। कुछ लिम्फोमास ऐसे होते हैं जिसमें हमें मालूम है कि शुरू में ही लिम्फोमा को ट्रीट करने के बाद में इम्पोर्टेंट होता है कि हम पेशेंट से डिस्कस करें, उनको हाई डोज कीमोथेरेपी दें और अर्ली ऑन ऑटो ट्रांसप्लांट करें, ताकि उनका लाइफ स्पैन भी एब्सोल्युटली नॉर्मल हो जाए। वेट करने से जब ये लिम्फोमास वापस आ जाते हैं तो क्योर होने का चांस कम होता जाता है। नहीं, ऐसा आजकल कोई वर्ड नहीं है, नहीं हो सकता।
डॉक्टर नायर, कुछ लोग कह रहे हैं आपने अपना वीडियो ऑफ किया हुआ है अगेन।
क्या आई रियलाइज जस्ट नाउ।
कोई फोटो देखिए, डॉक्टर नायर का फोटो नहीं दिख रही है, सो दे वांट टू सी।
नहीं,
डॉक्टर नायर, ये जितनी भी क्लासिफिकेशन आपने अभी बताई वो आप पेशेंट को बताते हैं या नहीं बताने की जरूरत समझते हैं?
बताना पड़ता है आजकल, और काफी सालों से हम बताते आ रहे हैं। रीजन बीइंग, जब हमें सब मालूम होता है तो हमारा जो डिटर्मिनेशन रहता है ट्रीटमेंट को हैंडल करने का, एज अ पेशेंट मैं बोल रही हूँ, वो बेटर हो जाता है, बिकॉज एवरीबडी इज नॉलेजेबल। अगर हम छुपाएंगे तो पेशेंट को हमेशा लगता है कि कुछ छुप रहा है, एंड देन दे डोंट नो whom to trust. If the doctor has told them everything and said that finally the bottom line in lymphoma is very important, it is highly curable, तो ये सेंटेंस जब हम एक बार ही बोल देते हैं तो चाहे वो स्टेज 1 होए चाहे वो स्टेज 4 होए, हॉजकिंस हो या नॉन हॉजकिंस हो, कोशिश रहेगी कि पेशेंट को क्योर करना है। सो एक बारी समझ आ जाता है बीमारी के बारे में, ट्रीटमेंट कितना इम्पोर्टेंट है, टाइम टू टाइम ट्रीटमेंट लेना कितना इम्पोर्टेंट है, पेशेंट्स कोऑपरेट मच बेटर। तो इसीलिए मैं जरूर बताती हूँ। दूसरी बात है, ट्रीटमेंट्स अलग अलग हैं। अगर हम देखें, कई पेशेंट्स को हम बोलेंगे ऑब्जर्वेशन में है, कई पेशेंट्स को हम बोलेंगे कि ट्रांसप्लांट तक फर्स्ट लाइन में जाना है। सो एवरीबडी विल वांट अ रीजन कि जो पिछला पेशेंट आपके पास आया था वो तो 4 साल से बिना ट्रीटमेंट के आ रहा है, और मेरे को आप कह रहे हैं ट्रांसप्लांट। सो व्हाई दिस डिफरेंस इन ट्रीटमेंट? एंड सो इट बिकम्स इवन मोर इम्पोर्टेंट दैट दे अंडरस्टैंड why we are doing what we are doing for that particular subtype of lymphoma. और पेशेंट्स तो बाहर जब वेट करते हैं तो सब डिस्कशन हो जाती है डॉक्टर्स के बारे में। सो इट इज इम्पोर्टेंट, दैट दे नो दैट why I am doing something for one and not for the other, not because I like somebody, but because I want everyone to be cured.
Yeah. So, Dr. Nair, when you keep a patient on observation, does the patient feel disappointed because you know that you have cancer, one has cancer, and you have come for a treatment with the doctor, and the doctor says, "No, we'll just observe you." So, does he think that the doctor doesn't know your disease? Does he think because we've always heard कि cancer हुआ है मतलब treatment फौरन शुरू होना चाहिए. Any delay in treatment can lead to the cancer spreading. So, how do you handle the situation with the patient?
So, then the important thing is counseling. And despite the best counseling, despite many years of experience, there are some patients who tell us, this is, too difficult to take, that I have a cancer. Here I'm sitting on a bombshell and you are telling me relax and come after 3.
Hmm. I think there's some problem with the
To basically control the disease, not eradicate the disease. We use the same treatment upfront. Sometimes the node is in the neck and it is really, kind of difficult for the patient because cosmetically it is unnerving for them. At that point of time also, we explain to them that the treatment now is more cosmetic rather than really treatment for the disease. And then the thing about keeping under observation is this happens mainly in the older lymphomas. These patients are all above 60, 65 years of age. And so by and large, actually, they are happier to understand that they can be kept under observation and they don't need chemotherapy and have the associated side effects. So I think generally the take that you need to be observed after a very, very good counseling is not that difficult. I would kind of almost remember one or two occasional patients in whom I really had to treat them because of the anxiety that it was causing, rather than because they really needed treatment. So there are a large number of patients who can be kept under observation because of their lymphoma. They do well. Many don't require treatment for a long time. And some diseases like CLL, which is chronic lymphatic leukemia, may have a normal lifespan, and at 70, 75, 80, they may actually have a natural death from other causes rather than from the lymphoma. So it would be wrong to treat them, give them side effects, and sometimes because of the side effects have very severe morbidity or occasionally a mortality also. So we have to be careful. Where it's not needed and should be discouraged.
So we have Shulmit here, who is working, who was based in Dubai and was working with the JD Marriott as a chef. And his life was changed because of his diagnosis of cancer, right, Shulmit? So what I want to ask you is that you were told that you have cancer and you have lymphoma. And so how well were you explain the whole thing? And what was your reaction? I mean, reaction to knowing that you have cancer, or I think almost everybody has the same thing. But
Yes.
how well did you know about your cancer, and how did you take it?
Yeah, so actually, it started in 2019. I was working with JW Marriott Mark. Like, I got a chance to work to the tallest hotel in the world, so I moved to Dubai, and I started working there from 2016. And my life was like every day working, then weekends parties, and everything was going on very well. And suddenly, when I was working, I realized that I have skin itchiness, like itching issues, and like letharginess. So I went to couple of dermatologists there in Dubai, and I took medications, but nothing happened. And so in 2019, I came back here. I left Dubai and I came back, and I met here in Mumbai. I met a couple of doctors in Leelavati. Specifically, there is Dr. Vaz in Leelavati Hospital. So उन्होंने actually मुझे check किया, और मुझे एक यहाँ पे node आया first. I showed him, I told him that there is something abnormal here. मतलब ऐसा कभी मैंने देखा नहीं था, ऐसा कुछ नोड. एंड उसके बाद उन्होंने मुझे बायोप्सी के लिए बोला, बायोप्सी करने के लिए बोला इन 2019 मार्च, एंड ऑफ मार्च. सो वो बायोप्सी मैंने एक्चुअली टाटा में किया. टाटा में इन बायोप्सी, सो वो टाइम पे डॉक्टर ने बोला कि इट्स अ कैंसर, हॉजकिंस, क्लासिक हॉजकिंस लिम्फोमा. सो फर्स्ट आई वाज लाइक पता नहीं अभी इसके आगे क्या होने वाला है, वो कुछ पता नहीं था. बट ही वाज कॉन्फिडेंट कि स्टेज 2 कैंसर इट इज, और ये क्लियर, ये हो जाएगा, इस मतलब इसमें कोई प्रॉब्लम नहीं, इसको हम लोग ट्रीट कर सकते हैं और इससे तुम बाहर निकल सकते हैं. एंड ही वाज कॉन्फिडेंट. एंड सो मैंने बोला ठीक है, हम लोग फिर ट्रीटमेंट स्टार्ट करना, मतलब ट्रीटमेंट स्टार्ट हुआ, कीमोथेरेपी स्टार्ट हुआ, एबीवीडी मेडिसिन स्टार्ट हुआ मेरा at Dr. Ashish Joshi in Mumbai Onco Care Center. So ट्रीटमेंट स्टार्ट हुआ. सो सेम मैं सेकंड ओपिनियन ले रहा था फ्रॉम डॉक्टर मंजू सैनगार, जो टाटा में है, टाटा मुंबई में. सो उनके पास से मेरा ओपिनियन चल रहा था, और वैसे ट्रीटमेंट स्टार्ट हुआ. फिर मैक्सिमम इन्फेक्शन एबीवीडी में चला गया था, बट उसके बाद लाइन ऑफ ट्रीटमेंट डॉक्टर ने वैसे बोला था. सो जो जीडीपी, एंड आफ्टर दैट मेरा स्टेम सेल्स ट्रांसप्लांट भी हुआ in April.
About Hodgkin, was there any other classification given, or you were just told that it is the Hodgkin?
No, just so I was under only Hodgkin's treatment. Treatment of Hodgkin's lymphoma.
But what happened after the initial treatment? Did it respond to treatment, or did it not respond after the first 2 cycles?
So as per my scan reports, response अच्छा था, but वो पूरा clear नहीं हुआ था after my 4 cycles. So that is the reason doctor ने continue करने बोला था with I guess GDP cycles medicines, right, and followed with stem cell transplant. So I mean it was वो experience थोड़ा, it was horrifying. It was very painful. Yeah. It was painful, no reason, but I was confident. And even Dr. Tapan Saikia, जिनके अंडर मेरा अभी भी ट्रीटमेंट चल रहा है. So he like before transplant I met him and he was confident कि he told me कि वो medicines harsh होते हैं, बहुत ज्यादा strong रहेंगे, but you can take it. And at the same time I was talking with she's a blogger, so she's a patient of Hodgkin's lymphoma, पर वो blogs लिखती थी. So मैंने कुछ उसके blogs पढ़े. I contacted him. She stays in Canada, so I contacted him via social media, and उनका भी same treatment हुआ था जो मेरा चल रहा था. So she helped me a lot. वो बताती थी कि कैसा, मतलब वो एक moral support मिलता था मुझे कि उनके थ्रू जो. हाँ, so that was, मतलब मैं mentally prepared था कि मेरे साथ मैं अभी क्या हो सकता है ऐसा. So वो मुझे अच्छे से एक help किया उसने. And yeah.
Go ahead, finish, then I'll.
Yeah.
So उसके बाद I was in complete remission after BMT in April 2021.
So now there are lots
2020, sorry.
Okay.
Yeah.
So now there are lots of questions which will come up. One is, like I said, Hodgkin's disease is highly curable. So we don't we try that everybody should get cured. And when we start treatment, we start with actually only for early stage, that is stage 1 and 2, we plan only for 4 cycles of chemotherapy upfront. For the late stage, upfront planning is 6 cycles of ABVD chemotherapy. There are other chemotherapies which are used across the world, but the standard in India has been ABVD because we get lots of patients who respond to this treatment. And if somebody doesn't respond, we have the backup of high dose chemotherapy, the salvage GDP that you mentioned, and followed by a rescue procedure, which is called as stem cell transplant, right? So what we are looking at each stage is after 2 cycles, has the patient gone into complete response? And that complete response we are looking for is in the PET scan, because that also gives us what is the activity of the disease. So if the PET scan shows that it has gone into complete response, it is a stage 1 or 2 disease, then we give only 2 more cycles and take an opinion from the radiotherapy friends of ours whether radiation is required, because we are shortening the treatment. The advantage of this is we are giving 2 types of treatment or only 1 type of shortened treatment. And Hodgkin's disease being a very curable disease, we don't want that 10 years and 15 years down the line, there should be toxicities of the medicines that we have used. Atreomycin can cause early cardiac problems and bleomycin can cause lung problems. And that is something we would not like at all, because we want everybody who's cured also to live a good quality of life and a healthy life, not have another disease to follow after that. Suppose it is stage 3 and 4, after 2 cycles, the patient goes into complete response, then we still like to reduce something at least, and we try to get away from bleomycin as a medicine, because that causes lung toxicity as we go on giving it, especially after the 3rd, 4th, 5th, 6th cycle. And in the earlier days, sometimes the lung toxicity used to be so bad that we have even lost patients who were in complete response but who had severe lung toxicity. So now the earliest that we can take away bleomycin after 2 cycles of chemotherapy, we try to take it away if the patient is in complete metabolic response, even if it is a stage 3 and 4 lymphoma. Once the treatment is over for both early and late stage disease, if they were in response, we again repeat the PET scan or the CT scans at the end of the treatment, confirm that it is a durable response and we need to give no further therapy. For patients who don't respond or who have activity at the end of 2 cycles, we give another 2 cycles and try to see whether this activity is going away. If it goes away, we follow the standard procedures of 6 cycles. If it doesn't go away, then we know that either we can increase the intensity of chemotherapy, and those are some treatments which are available from the Germans who have done a lot of work in intensive chemotherapy in Hodgkin's disease. And we borrow that and we change the chemotherapy, or we actually give them a salvage different regimen with completely different medicines. And if the lymphoma goes away on the PET scan, then we give them what is known as high dose chemotherapy, which is what works for patients in whom we didn't get a response upfront. And that high dose chemotherapy actually not only fires the remaining lymphoma cells, but actually damages a lot of our fast growing cells. And so in order to rescue the fast growing cells and allow the effect of the chemotherapy to damage the Hodgkin cells, we remove the patient's blood cells or stem cells from the peripheral blood, store them, give the chemotherapy, and re-inject the stem cells into the patient so that their normal cells are rejuvenated at the fastest. So this is what is the high dose chemotherapy and auto transplant, which happens for some. Many people will ask, why don't you do all of it so that everyone is cured? The reason why we don't do is because all these procedures are tedious. He is himself saying how much support he required, not only physically, but mentally also. So if we look at the outcomes and we look at early stage Hodgkin's disease, then ABVD into 2 cycles puts almost 80-90% of the patients in response. less than 10% of patients don't respond. At the end of 4 cycles, it goes up even a little more than 90%. So you're looking at 7 or 8 out of every 100 patients who may need more therapy than the standard ABVD. Even if we look at the late stage disease, we know that almost 60 to 70% of stage 4 diseases also will go into complete response. They have a higher chance of relapse in the first 2 years. So we feel it is better to follow them so that the 60% who are not going to get this disease back, we should not unnecessarily do a high dose chemotherapy and a transplant. And for the patients in whom it comes back, which is about 3 out of every 10 patients in late stage disease, we can still salvage and cure at least 2, if not all 3 patients. So the results of Hodgkin's lymphoma, if they are treated well, hardly 10% of the patients will, kind of be resistant and still get the disease back. And now there are very good drugs even for patients who have multiple relapses.
So now I know why Dr. Reena Nair, I was congratulated when people came to know that I have such. And they said, if you I was wondering, why are they congratulating me? And they were saying that if you had to have cancer, then you got the best cancer. Though it was phase 2, they were very, very confident that it's going to be taken care of. And they just said ABVD makes it all melt away and there will be no cancer left. And today, after so many years, it's still nice to hear that ABVD is working and you have the same opinion about ABVD. Of course, newer treatments have come up. But Dr. The ABVD is the standard for all cancers, or have things changed, or just given because of the cost of it? Because I know the cost has come down a lot of ABVD since the time it has started to now. Would like to add on to that?
Yeah, the reason is that Hodgkin's disease is or Hodgkin's lymphoma is not only one of the curable diseases, it is also like they say, it is the best teacher for oncologists because it has taught us many things. First is that there is a cancer which can be controlled. That was in the 1960s and or maybe 1940s to 60s, when only radiotherapy used to control and keep it controlled for quite some time. Then came up different kinds of chemotherapy, and the first example of, or the first outcome or a good outcome of World War II was understanding that some of the nitrogen mustards that they used as warfare actually kind of shrunk the lymph nodes. So I think wars are very bad, but this was the only outcome, that chemotherapy can make a difference. And so when we started giving chemotherapy in the 1960s, we realized that reasonable number of patients are getting cured. Then, like I said, with the present treatments and the German Hodgkin protocols, they reached almost 95% patients would get cured, but it was a very intensive therapy. Every 15 days of aggressive therapies, lots of supportive care, extremely expensive, also had a lot of toxicity. And we required a lot of hospitalization and blood and other antibiotic support. So the cost and the finances was the initial toxicity. And Hodgkin's lymphoma is a disease of the young patients, and many of them have not even started their families. And that kind of an approach caused sterility, which was almost 100% in men with the very intensive therapies. So the next thing that Hodgkin's lymphoma taught us was reduce the treatment or truncate the treatment or abbreviate the treatment. You don't need to give so much to everybody. And even if you have an occasional patient who actually gets the disease back or doesn't respond, the second line is just as effective. Second line also cures 70 to 75% of the patient, which actually doesn't happen in any other cancer. So everybody started discussing why create toxicities 10 and 15 years later just because it is a lymphoma and we want to cure the patient today. Why are we not looking at what happens to these patients 10 and 15 years later? So don't continuously go on giving ABVD. So we have now truncated treatments, we reduce treatments, we give abbreviated doses. In some stage 1 Hodgkin's lymphomas, which are called as favorable Hodgkin's lymphomas, we actually just give 2 cycles of ABVD and a little bit of nodal irradiation, and they are absolutely fine for the rest of their lives. So that little is the treatment. We hardly see those kind of patients because by and large, by the time the patient comes, it is not really that early, or their ESR has gone up, or their stage doesn't fit into the favorable group of patients. And so in India, most patients actually are early stage but unfavorable group, not the favorable. But we can come down to that level of minimum treatment. And so again, it taught us that you can reduce treatment because you have a very good salvage therapy for those who have a problem afterwards. And so don't give toxicity to everybody. And then of course now we have this time of let's call it targeted therapy, and everyone says don't want chemotherapy anymore. Chemotherapy has done its work for the last 40 to 50 or 60 years for certain, but then why take chemotherapy when we have nice targeted therapies available which are far less toxic? The only toxicity just now is the financial toxicity of these drugs. We have what are known as monoclonal antibodies, and Hodgkin's lymphoma patients have what is known as CD30 expression on their lymphoma cells. And we have a very nice drug which is called brentuximab vedotin, which is an anti-CD30. So we have always been unhappy with bleomycin because it causes lung toxicity, and no doctor or no family likes, that their patient should. You can still accept if the disease doesn't come under control that you lost the patient, but losing a patient to toxicity in today's world is the most depressing thing in oncology. And so there has been all this action to rid ourselves of bleomycin because we really don't know what is the dose which causes toxicity. Some people are very sensitive, and in a very few injections, they may get a lung which is fired forever. So we have replaced the bleomycin of ABVD with what we call as brentuximab vedotin. And these are now treatments which are available worldwide, except for the fact that it costs about 300 times more than ABVD. So we use it very sparingly in young patients who have, a lot of disease, because it does make a difference in the 5-year outcomes of patients who have taken brentuximab versus bleomycin with their ABVD. Having said that, the cost difference is so much, the outcome difference is less than 5%. And so we have an occasional patient in whom we do give brentuximab upfront, but by and large, the standard for a country like India remains ABVD, where the treatment is fully outpatient, where there is hardly any toxicity, where the support systems that are required like blood, platelets, growth factors, antibiotics is the least of all the chemotherapy regimens that we use. And like I said, where the cure rates are the highest for early stage and pretty high for the advanced stage patients, with the backup of salvage chemotherapy and an auto transplant after a high dose chemotherapy available.
So Dr. Nair, that brings me to a very silly question from your point of view. What are the normal signs and symptoms for any lymphoma, whether it is Hodgkin, non-Hodgkin, or the various subtypes of Hodgkin? Because I know that it can get confused with TB, and now with the, I don't know about COVID, how much it affects or not, does not affect, or whether you can get the symptoms confused. So if there's some clarity on the symptoms that we are talking about, how does a lay person who has got a problem think that it could be, because one thing is you don't want to think it's cancer, but to be early at the same time, that the earlier you go for treatment, the better is the possibility of your getting cured. तो हर कोई चाहता है कि जितनी जल्दी पता चल जाए, लेकिन एग्जैक्ट सिम्टम्स क्योंकि बहुत कंफ्यूजन है उसमें, बहुत चीजें मिक्स हो जाती हैं, whether it is Hodgkin's or non-Hodgkin's. So would you like to elaborate a little on that?
So the symptoms is something, let me tell you, not only lay people, the doctors and the general practitioners, we all miss it, including oncologists will miss it. The reason being, just like you said, that people confuse it with tuberculosis, and in our country tuberculosis is so common that in the general practice, if a person or a GP is seeing patients who have come with the symptoms which are common, that means like you said, lethargy, fatigue in the evening after working hours, maybe a mild grade fever in the evening, swelling somewhere in the body, losing weight. These are all common to both tuberculosis and to lymphomas. And for a general practitioner, every patient that he will be seeing will be tuberculosis. He will miss one lymphoma in a lifespan of 10 years of his GP practice. So lymphomas are that rare. It is something, if you put 100,000 people into a room, only 2 will have lymphomas in their lifetime. So, you can imagine it's like finding a needle in a haystack. So it is really difficult. But the warning signs for any malignancy is if treatment for tuberculosis has started and you are not improving on it, if you have nodes which are increasing, any swelling which is increasing, any fever that is unexplained and is long drawn out, 2-3 दिन का fever होएगा, उसमें सोचना कि मेरे को lymphoma हो गया है, is not correct. There should not be a fright in the population and in the general public. So this is something which is really, really rare. If whatever you are being treated for does not come under control, then it is always a good idea to take a specialist's opinion or a second opinion. And if there is a swelling somewhere and is not coming down with the initial course of antibiotics or the first 4 to 6 weeks of treatment for tuberculosis, it is a good idea to biopsy it. And I will emphasize that an FNSC which is done and is negative does not tell us that there is no disease. So it is a biopsy which is very important for a lymph node that is not responding.
Thank you, Dr. Nair. Shulmit, I wanted to ask you something. You decided to come to India for your treatment, right? And so in India,
Yes.
you came to India and you went to Prince Ali Khan only for your BNT, or the stem cell transplant, or you were there for the entire treatment?
No. My stem cells transplant is done in Prince Ali Khan Hospital under Dr. Tapan Saikia, and my ABVD and GDP it have done in Mumbai Oncocare Center under Dr. Ashish Joshi. And I was taking second opinion from Dr. Manju Sengar in Tata Hospital.
So tell me something, for you to come from a very interesting job that you had, something which you were looking forward to, and coming back to Mumbai and settling here because of your treatment. What were your thoughts as a youngster?
So actually, I as I said, I went to a couple of doctors there, but there was no outcome. I could understand that itching was increasing, and I had night sweating also, which was increasing. So that's the reason I thought there's something is wrong, and I guess I had to go to India for it. And at the same time, my visa was getting it was getting expired, and the HR, they asked for the renewal of visa. So I said I don't want to renew it, and I'll resign, and I'm going back for medical reasons. I came here and I just thought, like whatever dermat issues are there, that will clear it out, and then we'll move again. I'll move again somewhere else. And all these things happen. Treatment of blood Hodgkin's lymphoma in between this, and again, like after BMT also, for next 1.5 years, I was clear, and I was about to start my work. Last year in October, I just thought I'll just check again my blood tests, and I'll do my blood test. And in October, those blood tests, the lymphocytes were on a higher side in that blood test also. So I went to my doctor, Dr. Ashish Joshi, and he was like, "We'll check." And I found one node here. It was relapsed actually in October. Right supraclavicular here on this side, there was I felt something here. So I went to doctor again. I told him that after my blood test in 3-4 days only, I felt this. Like I was about to start my work again after the treatment. And he told me that we'll do biopsy. If you like, he suggested sonography first. In sonography, they found something, that there is something in here. Then he asked for biopsy. So I've done biopsy, and there was a relapse, a node of approximately, I guess, 8.7 centimeters. in last October. As doctor said, Dr. Reena said that the medicines, they have advanced medicines for that. Like I have undergone brentuximab vedotin and nivolumab, the combination of immunotherapy and targeted therapy for 8 cycles, from October to April of 2022. I have undergone all 8 cycles. In May, doctor has said, I have undergone PET CT again in May. And again, second time I was under complete remission. So now I am just going under immunotherapy for 1 year, as doctor have suggested. So I'm like this, that immunotherapy, I'm like that treatment is going on at the moment. It is not painful at the moment, but financially it is, I mean, the medicines are very expensive. And as I don't get those, like those medicines are not available in India. I had to order those medicines from outside. Like at that time I got three options. US, US and what? Istanbul, Turkey, and Switzerland. So I chose Turkey because of the currency exchange. It was cheaper than all other two. So like in last 2 years, I was just struggling with lymphoma. Now at the moment, I'm feeling absolutely fine. Probably from next month, I'm going to start my work again. And as doctor have approved, like doctor said that I can start my work slowly, because while taking brentuximab vedotin also I had side effect of choking while taking the treatment. While taking the infusion, I had a side effect of choking. I'm assuming that was the allergic reactions. So doctor used to give me adrenaline sometimes, or the non anti-allergic medicines while taking the medicines. So that is the reason I couldn't work that time. But now while taking immunotherapy, I don't have any side effect as such. And doctor have gave me the permission also to start my work. So probably from next week I'm going to start my work. Like I was just looking like when I can start my work again, because from past 2 years, because of my treatment and of course because of COVID, I couldn't work, because after BMT my immunity have dropped down drastically. Because as I know that, yeah.
No, sorry, complete your sentence.
No, so like as I said, the cells, like after BMT, those WBCs and hemoglobin completely it was zero, and it starts again after they infuse that my stem cells again. So my immunity was on absolutely lower side, and that is the peak time of COVID. So I couldn't go out of my room also.
So,
So
Dr.
last
Nair,
2 years,
what
yeah.
you heard from Shulmit brings us to three things that I would like you to answer, please. One is about the late side effects. This, of course, has happened very soon, but it can happen that the side effects of the treatment that he has taken come in very late. And so, are you like following up with the patients, or do you tell them about the late side effects, or how does the patient know? That's number one. The second thing is, we hear these words, immunotherapy and CAR cell therapy and all that, in a very big way. And everybody thinks these are the miracle medicines and they are the ones to be used. But then are they available in India? And what about the cost factor of it? Maybe Shulmit could afford it, but there would be many people who cannot afford. So what do you do in such cases? Whether, the medicine is given or not. And the last question is that, he is working, there may be somebody who's a student, and they need to go back to their respective areas of activity. Does a doctor explain it to the patient, the caregiver, and also, if need be, to the workplace or the school about how to involve them and get them back into their, get them back into their personal activity? Because I've also heard of somebody who said he was taken into a job but was asked to sit separately because they thought it was an infectious thing. So would you like to talk about, I may have put too many questions, but.
Okay, so I'll try to do it fast. I think we have a little short of time. So the fact is that, we recently looked at a large number of Hodgkin's disease patients in whom we have treated upfront with ABVD across 9 centers in the country. And we realize that when the disease comes back, less than 2% of our patients can actually take any of these treatments. So in India, perhaps the first chance is the best chance for most of the patients, and we have to see that, the treatments are given on time and we take care of our patients. Having said that, despite taking treatments on time, we know that 10% of the patients don't respond upfront. They have progressive disease, and another 10%, depending on the stage of the disease, it is likely to come back in the first 2 years when the chance of recurrence is the highest. If it doesn't come back for the first 2 years, and definitely not for the first 5 years, the chance of this disease coming back is a little more than the normal population, but it is not very high anymore. So we have to take a lot of care during the 2 to 5 years during which the patient has completed therapy, and make sure that if it is coming back, it is caught at the earliest. We really worry because if you see what happens to Hodgkin lymphoma, young patients who have been treated with, all chemotherapies, all radiations in the, let's say, in the 80s and 90s, then we know that if you follow up for a long term, they have taken all the adriamycin, all the bleomycin, and at that time the radiation also used to be, very extended, because we believe that Hodgkin spreads by contiguity. That means from one node to the other, and we would try to cover up as many nodes around the actual disease site. And so it used to be very large radiation fields. And so we have patients who have cardiac problems 10 and 15 years down the line, lung problems. Young girls who have been radiated in the chest have this predisposition to breast cancers. And because of the two combined and the kind of drugs we have used earlier, there is always a chance of getting what is known as acute myeloid leukemia or a myelodysplastic syndrome. So all these malignancies have shown up as second malignancies, and the reason to reduce the treatments is because of them. Also, now we have these checkpoint inhibitors, which is the immunotherapy, and we have monoclonal antibodies, which is the brentuximab-like therapy. We have realized it is early disease. I would say it is early results. But if you look at the 5-year follow-up of some of these patients, it is actually 100%, which means either they have been given 3 to 4 cycles of nivolumab, which is the checkpoint inhibitor or the immunotherapy, before giving them AVD, or they have been given brentuximab with AVD. And we find that when we have given them the two new drugs in combination or single with chemotherapy or followed by chemotherapy, very few patients have been treated, all in the US, all in clinical trials, but we first time see that there is no patient who has relapsed, which is such a fantastic thing to happen. And if we can reduce the chemotherapy further and use only a combination of these two, and the prices come down, you can imagine how good it will be. No chemotherapy side effects, not to worry about the long-term side effects. At the same time, everyone with Hodgkin's will be cured. That is a dream, but it is not very far away. It is coming, and we can see that coming. You also said, what do you do with follow-up? Yes, for the patients whom we have treated in the 80s and 90s, we are particular with the follow-ups. We are not stopping their follow-ups. It may be once in 2 years or once in 5 years, but we continue to look. And we don't always do the echocardiogram or ECG, but we look for symptoms. And at the earliest symptoms of what can be cardiac, pulmonary, or a chance of a second malignancy, we investigate them fully. We haven't yet said that you can't follow up with us, more from looking for toxicity, because the relapse rate, I think, come down by 5 years, and we don't really worry so much about relapse in Hodgkin's lymphoma. For non-Hodgkin's lymphomas, it is completely different. The low-grade lymphomas need a lifelong and a repeated and a 6-monthly review, because they keep on relapsing, getting all right, relapsing, getting all right, and we can maintain a normal lifespan for them with treatment, off treatment, treatment, and off treatment in that way. And the other curable non-Hodgkin's lymphomas in the children, again, we follow the same principles as Hodgkin's. We intensively treat them, but we follow them up after 5 years, mainly for toxicities.
So what about, like I was talking about the schools and the workplace and all that?
So I have, kind of seen that most good workplaces have actually been very kind to the letters that we send when we say, let this patient who has just completed therapy start a light duty. See, it's very important to occupy your mind when you're on treatments like this, because otherwise you're only thinking, why me, why this, why that. So, if you're occupied, I think the treatment takes a lesser toll. It definitely takes a toll on your physical being, but at least, if your mind is occupied, you can still carry on with the treatment and you're doing something. So I would encourage everybody to go through treatment and to continue to think that they're getting back to work. I think I used to be harsher in my younger days when I used to tell everyone 7 days, 10 days, and then go and join the office for 3-4 days and then come on day 15 or day 21 and I'll give you the next cycle. Now I've become a little more mellowed down with age. I don't insist that you go back, but I still think it's a good idea with work from home and so many other things which have come up. We should encourage all people to work. We don't like them to work in places where they can be prone to infections. So the healthcare workers are at a risk when they are on treatments, and we prefer that they don't go back to their hospitals. For most others, where they work in clean areas or have a clean office and don't interact with too many people who are infected, I think everybody must get back to work at the earliest, not even wait for treatments to get over, as soon as they feel physically good. And going to office for 3-4 hours, 2-3 days a week, if the office permits, with the kind of letters that we give, I think that is ideal for most patients on treatment for Hodgkin's and non-Hodgkin's. I wouldn't say it's the same for all cancers, but for lymphomas, definitely it can be done.
Yeah, I remember that, when I had cancer and you had told me the first 3 or 4 days, be at home, don't move around. And the last 1 or 2 days, don't do anything because then you need to go for your next cycle. But the rest of the time, you must work. And that was something which I really followed to the T. And it was very, very helpful, because I wasn't thinking about cancer in those days. But, we have Shulmit, who has another problem, in the sense he has another challenge to face. His mother is undergoing treatment for breast cancer, right, Shulmit? So, how do you manage the two things? Because it must be very hard on you because your mother is not doing well. She's got breast cancer and is being treated. And here you are with your treatment. There will be so many, factors which come. The financial part of it, the looking after part of it. Shulmit, we can't hear you.
Ma'am, I couldn't hear you actually. Can you hear me? Huh?
Yeah, I can hear you. I said, you are facing a double challenge because your mother is also undergoing treatment, right, for breast cancer?
Yes, for breast cancer.
Taken care of. So how do you manage the two? Because it must be
double.
Yeah.
Yes, actually, in December, we came to know about her. She got a small lump, so she checked her. She went to the doctor, and then it was a breast cancer. But we at home, actually, the time when I diagnosed with cancer, we decided we are going to we all of us are going to stay together. Like my parents, my sister. She's married, but we all stay together, and we never talk about my cancer situation and everything at home at all. So we just talk about what exactly we are going to do at home. Just other normal things, but never about the cancer. So those things, वो कभी बातें होती नहीं थी घर पे कि अभी मेरा ऐसा चल रहा है, मेरा नेक्स्ट इन्फ्यूजन है. सो मैं कभी उनको दिखाता नहीं था कि मुझे क्या हो रहा है, कि मुझे प्रॉब्लम्स हो रहे हैं या आई एम इन पेन या ऐसा कुछ मैंने कभी उनको दिखाया नहीं. डॉक्टर से मेरी बातें होती थी हमेशा. सो आई यूज्ड टू टॉक विद डॉक्टर्स ओनली स्ट्रेट. सो जब तक मैं नॉर्मल हूँ या मुझे अगर कुछ प्रॉब्लम, जब तक मेरे पेरेंट्स दिख रहे कि आई एम नॉर्मल, देन उनको कोई पैनिक, उनको कोई ये नहीं रहेंगे, टेंशन नहीं रहेगा. सो मैं खुद को हमेशा नॉर्मल रखने का ट्राई कर रहा था घर पे. आई यूज्ड टू स्लीप अ लॉट आफ्टर दोज हेवी डोसेज ऑफ कीमोथेरेपी. आई यूज्ड टू स्लीप फॉर 15-16 आवर्स अ डे. सो अगर मैं जगह आफ्टर कीमोथेरेपी होता है उसका नेक्स्ट 2-3 days आई यूज्ड टू स्लीप अ लॉट. तो कैसे अगर मुझे कुछ प्रॉब्लम हो रहा है, देन if I'm wake up, then only I can understand that I'm suffering from something. If I'm sleeping, there was no issues. I mean, no problem. So for next 2 3 days, and I kept myself very busy at home. After like 4 5 days of after the chemotherapy, 4 5 days, I used to cook a lot at home. My sister and my brother-in-law, they brought of different platters, plates, all crockeries, nice good crockery. So I used to cook at home. I used to take photos of that, and I used to upload on social media on Instagram. So I kept myself very busy at home. So,
So
वो
Shulmit,
कुछ
when are you
दिमाग में नहीं
calling
आता था.
the next meal? When are you calling us for the next meal? In
Anytime,
the
anytime, anytime. Yes, and
then
plus point of that, yeah, the plus point of that, like yeah,
bolo, the plus
yeah.
point.
So, yeah, so like I posted around like 70 75 dishes on my Instagram account, different, all different recipes. So, and I got a job offer because of that. I mean, my boss, he just saw my profile. Like I put that Instagram QR on my resume. My boss, he saw my profile, and probably from next month I'm started working again.
Oh, good.
Because
That's
like
nice.
I wasn't like staying and doing nothing. I was cooking at home. Like after chemotherapy, 3 4 days I used to sleep. On fifth day, when I'm okay, I started cooking. Like my sister, she used to click pictures because she's very good in pictures. I don't know photography at all. So I used to cook. My sister, she used to click pictures, and then I used to post it on Instagram.
So Shulmit, you
Anything like,
feel
yeah.
this way, but how about your mother? How is she coping with it?
So she now actually she's done with her surgery and chemotherapy and everything. She's and radiation as well. She's doing good. As even it was safe with her. Like she had 4 cycles of chemotherapy. After every chemotherapy, I used to tell her just go to sleep. Sleep. It is okay. No, nothing is gonna happen for next 2 3 days if you sleep continuously. So she used to sleep a lot, and for meals, for lunch, dinner, or like evening, thoda sa chai and all, I used to wake her up that time. Otherwise, I mean, I can understand. I mean, she's 60 plus. I know how painful it was for me, so I can understand. So matlab, I always told her to sleep. Those 4 cycles was painful for her. Like after that radiation, she took it very well. And the plus, I mean, the good thing is I have, like, after this relapse, the medicines were doing their work, no doubt. I mean, but along with medicines, I have changed my my lifestyle, my diet. I have changed drastically. Like I used to eat, like, I'm a chef, like I used to eat a lot of junk also because of that. Many things I used to eat. So I have stopped many things to eat. Like I don't eat any kind of sugar. No glucose, no sucrose, no fructose, no fruits, nothing. The food material which has sugar, I have stopped completely. She knows that. She saw my the changes of my like daycare routine. She saw that, and she started doing the same thing. I have, while taking immunotherapy.
1 minute before you go further. Dr. Nair, is
Yeah.
it a good idea to stop sugar altogether? Because these are the WhatsApp messages which come very often. No sugar for cancer, no milk for cancer. Is there something like that?
I am a strong believer of eat everything, because when somebody is on chemotherapy, it's so hard to say. Uh, so I believe, but I'll tell you one thing. I was listening to him. His faith in that is so much, that I would not like to shake it at all. But for patients in general, I would say in moderation, eat everything. Earlier, we used to be very strict with fruits because we thought that they may not be well cleaned and they may not lead to infections. But now I give the patient the responsibility. Wash it yourself, peel it yourself, cut it yourself, and eat it yourself. And then I'm not worried that something will go wrong. So I allow them to eat fruits also. So if your mom likes it, let her choose her own path. There is nothing that somebody
Yes.
has to give up completely. Huh? Because I was wondering,
Yes.
if you're a good chef and you've given up all this and you're making others eat, people will question you.
No, maybe it was because of my medical issues.
Yeah.
And but I hired a nutritionist and a fitness trainer who used to train me. He's from Pune. His name is Omkar. So because of him, I would say I came on a right path. In terms of my fitness, I've started doing yoga and workout, and of course the diet, and that helped me a lot throughout my treatment. Because uh first like I lose a lot of fat. Like I lose almost 12 kgs in 7 months, and that was complete fat loss. I can feel it. I feel so energetic after losing a lot of weight. I feel so energetic. I started eating very good food, like green vegetables. You can say in protein, I eat paneer, chicken, fish, grilled fish or grilled paneer, boiled chicken. I started eating all these things. I gave up rice. I gave up rotis, chapatis. I mean the things which has gluten or starch. I've stopped eating that, and that helped me a lot with that. And same my mother, she saw that, and she saw the change, that all the changes in me. Like I was so energetic after after my session. Like next day I used to go for yoga, and I used to go for walk also, straight to next day. Like iske pehle I used to sleep for 2 to 3 days after infusion. Same with brentuximab and nivolumab also. I used to sleep for 2 to 3 days continuously. But when I changed my lifestyle, when I started doing yoga, uh, workout, and eating clean food, good food, I don't know, but suddenly a lot of changes happened. And next day of infusion, I've started going for a walk, or I've started doing yoga next day in the morning. And that was, I mean, those days were not painful for me after infusion days.
So, Dr.
And I
Nair,
mean, yeah.
question I wanted to ask you. Are there a lot of clinical trials being done on for Hodgkin's and non-Hodgkin's? And are they being done in India? Because I find that most of the clinical trials are happening in high income countries. And those are then transferred to our country, which is supposed to be in the lower middle income category. So, is it fair for our patients to undergo that or take the medicines for which they've not even had a trial and being done abroad? So, do we have trials in India, or is it only what is being done in the high countries that it comes to us and we take it?
So, needless to say that the best trials and the best drugs are tested outside. We have very, very few trials over here because we took a hit, I think, for almost 5 to 7 years, when lots of legal aspects had to be put in place for clinical trials. And we are much, much behind what we used to be in the 90s as far as the clinical trial scenario in India is concerned, even today. So initially it was the legal hit, and then after that it was Corona. And so we have very few. What we normally do is, and this is something I advise all my youngsters who are, into treatments of lymphoma in other areas, is we do believe that we have no reason to believe that ABBD didn't work or the aggressive therapy BACOP didn't work, though the trials were done in the West. And so that the new drugs will not work in us because the trials have been done in the West is not something that I will buy, because they actually make a lot of difference. So a lot of these drugs we get on what is known as compassionate access or name patient access. So some of them who could afford, and we've been using brentuximab almost since 2012, 2013, I think was the first patient we used over here. And we have a large series of patients now in whom we have used brentuximab and seen the difference that it has made on what would have otherwise been a very, very resistant Hodgkin's, and we would have kind of said, okay, no further treatment, and we would have lost those patients. So we have a whole group of patients in whom we have been able to make a difference. Of course, they got it on a named patient basis, but they had to pay for it. We now get a lot of the new other monoclonal antibodies and bispecific antibodies for non-Hodgkin's lymphoma, which are coming through compassionate access. And we have a very good system put in place where one doctor and one customer care or a secretary does all the paperwork for our patients. And so those who are not responding to the regular treatments, we make sure that whatever can be brought on compassionate access, we bring it for our patients. And that, of course, has the advantage that it is free of cost for the patient. So even more expensive drugs, we sometimes get free of cost for some of the patients. Needs a lot of effort, both on the part of the family. They have to stay here. We can't give it to them to take it away. And at the same time, for the amount of paperwork that goes in, because they have to be careful when they are sending these. So no, we are not doing the kind of clinical trials in lymphomas, or for that matter, in most of the oncology areas, which we were doing in the 90s and the early 2000s, because of things that went wrong. I'm glad that things have been put in place now, and Corona is over by December for certain, and hopefully those trials will now come to India, and we will become a part of them.
Thank you, Dr. I know we are running out of time, Shulmit. So any small message that you would like to convey to your fellows or to people who have lymphomas or who are undergoing treatment, who may be young or old, any one line message?
Yeah, sure. I just wanted to say, like, from my experience, that it is difficult. I mean, people say to be positive or stay positive, but I can completely understand it is difficult. But I would say that keep yourself busy in something while taking the treatment. Also, keep yourself busy in whatever you like. But like, if you didn't do anything and just thinking about it, it is more it might create more damage to you like, I mean to say, mentally. So I think, and from my experience, I think everyone needs to be on proper diet and keep your body, doing by doing yoga or workout, keep your body also in I mean good maintenance physically as well.
Dr. Nair, before I ask you to give one line message for your patients and for others, one thing that happens, especially with youngsters who are not married, that whether they should get married or not, whether it's a good idea, whether they can have children or not, I think this point is often overlooked and not discussed. So even if they come to a patient support group or talk to somebody about it, we are at a loss to really tell them whether it's a good idea to get married, because they want to hear it from the doctor. And also, we are not sure whether it's a good idea for us to tell them, because we don't know the medical background. And we always say, you must talk to your doctor what time you can get married and what's a good idea. But do you, as a doctor, talk to the patient and the family about it? Because only then the awareness about marriage can grow. And that will make a lot of difference, especially in the youngsters. And then, of course, your message.
So Hodgkin's disease is a disease of the young, and we have to take the fact that they are young very seriously from the very beginning. So one is, at the time of counseling, we have, especially for the little, let's say, young adults who are unmarried, we have to discuss fertility and sterility issues. In the discussion, there are so many things happening that most families feel, acha ye rehne dijiye kyunki ye to bahut, because for them they are losing somebody who's very dear to them, and they are not at all thinking of what is the future for that particular individual, and they would like to avoid it. But for all the young men who are unmarried, we do suggest that they do sperm banking. There will be a time when we will have oocyte preservation also. It is already happening in some centers, not as easily available across the country as sperm banking is. It's a good idea, despite the fact that ABVD is a treatment which causes real sterility in less than 20%. The older chemotherapies which we used to give used to cause sterility in almost all the young boys. So we always feel that that is an important thing that we need to discuss upfront and give it some time while we are actually doing the investigations, doing the staging, getting the groups and subgroups recognized by the pathologist, we all get time. There is no hurry to start treatment for a Hodgkin's lymphoma. 7 days delay is not going to change the outcomes. We also keep the sperm banking in place because we don't know, but it is known that patients who get a lymphoma, Hodgkin's lymphoma, inherently may have a low sperm count also. So that also needs to be assessed, because otherwise in later years, somebody will say that it was your treatment and now I'm going to sue you. So doctors also have to be a little careful. So it is a good idea to do it. That is a message to the doctors. When it comes to finishing treatment, for the first 2 years, we prefer that, somebody doesn't take the decision of, I'm not against marriage, because see, marriage is between two people. And if your partner already knows what you're going through and has no problem, then there's no point in saying that, okay, don't get married, because, tomorrow anything can happen to anybody. But don't have your family, because the patient, who, whether it is going to be the mother or the father, has taken so much of chemotherapy that if there is any damage to the sperms or the oocytes, we believe that there can be children who will be born with some kind of a defect. Though in my clinical practice, I have never seen that. What happens is abortion is something that happens to babies which are not being born, and so the risk of abortion is higher. But the children who have been born, by and large, to all my patients who have been treated, have been pretty normal. So we like them to be born a little later, when perhaps the whole chemotherapy has been washed out of the systems. We also speak to families 2 and 5 years later. If our patients want to get married and it is an arranged marriage, the first thing we tell them is, please tell them beforehand, because tomorrow if you get married and 3 months down the line this disease comes back, you are not only going to face the disease, you're going to be alone, and then you will have the people telling you what wrong you did to them, rather than anybody looking after yourself. And that would all be terribly sad at that point of time. And then if they want to bring their fiancés to come and speak to us, many of them have brought their fiancés. I have had a discussion, and many people have gotten married. So I encourage that normal institutions of life, normal way of going about life must be there. If somebody does have sterility, and for reasons that at that point of time sperms were not donated, or it is a lady in whom we didn't have facilities, we do discuss adoption, surrogacy, and so many other things with the family, and whatever is the most suitable between their obstetrician and us, we try to advise them so that they live a complete life. And many of my patients have adopted children because they could not have their own children after they have completed treatment. So I would say go through all the goods and bads, highs and lows of life, because if you are not married, we will keep thinking how lucky you are, and we had to suffer all of it. So I think everyone must go through everything that needs to be done. My last message will be not one, but two. Always remember, lymphomas are the most curable diseases. So even if you get it, despite what stage, don't give up. The way the new drugs are coming, I don't think we are going to give up. As long as you keep coming, there will always be an attempt to make them available to you. Sometimes I tell my youngsters, beg, borrow, or steal, but get the new drugs for your patients, because so many of them, I will say so many are figures on the tip of my fingers just now. But when I see them coming 2 years, 3 years, 5 years down the line now, after the drugs that they have taken, I feel really happy that we could do it for them. Most important to remember that doctors are sometimes really unapproachable, because they are seeing patients one after the other, and they find themselves to have become repeated records, the HMV records. So sometimes they don't tell you so many things in a hurry, or not because they don't want to, but it's just shortage of time. The support groups which have come up are a huge support to the doctors. And so they must be also a great support to the patients. And I encourage all of them to get into a support group, because nothing is as good as a patient who has gone through treatment telling others what is to be done, where to get help, what to do next, that counseling is something I think the doctors can't give, but the support groups give. So we have to make it a habit that not only for lymphomas across cancers, but definitely for lymphomas, every patient should be associated with the support group on day 1, if not on day -1 of their diagnosis, not treatment. Yeah. Thank you.
Thank you very much, Dr. Nair. Thank you, Shulmit. I just want to add on that WeCare as a foundation has been working with patients for the last 28 years. And our idea is that nobody should feel that they're alone, and that they should not feel that this is a question which they can't ask somebody. They can ask us. If we don't know the answers, we can get in touch with the doctors and then get them to know the answers. So you should not have any anxiety in your mind about your treatment, about not knowing what it is. And that is the role of WeCare, and we hope we are able to achieve that role. Fortunately, because of lockdown, good or bad, I don't know, but we've been able to have these webinars where we are answering questions of the patients. Today, all the questions that they were put up have been answered by our doctors, and our doctors have been very, very supportive. And not only today, but I must tell you that from the time WeCare was set up, we could go to any doctor. We were not trained medical people at all, but each doctor was willing to answer our questions or willing to give seminars for us so that we could be educated to give the right type of information to the patient. And I think in the support group, that is what really matters, because we don't have to give what we know, but we have to give what the doctor wants us to tell the patient. And I think that is an important part of it. So thank you once again. And I'm sorry we've gone a little overboard on time, but we could still go on for another 1 hour and have so many other discussions. But thank you. Maybe another time, another seminar, and we'll do that. Thanks a lot, Dr. Nair.
Thanks. And all the best, Shulmit.
Thanks.
Thank you so much. Thank you, doctor. Thank you.